Hi everyone, I'm Shruthi Ram, co-author and faculty at Brown University. I want to talk to you about our study, Community-Based Breast Cancer Screening Using DBT versus DM, Comparison of Screening Performance and Tumor Characteristics. So I want to talk to you about the study in terms of three questions. Question one is, what was the purpose of our study? Well, there's been increasing utilization of DBT for screening purposes in the U.S., and evidence for using DBT includes studies that show lower recall rates and improved cancer detection rates, particularly of invasive cancers. But most of these studies have been prospective trials and at academic centers. We are currently lacking long-term data on DBT mortality outcomes, so potential surrogate markers for assessing DBT versus DM impact on mortality include differences in interval cancer rate and differences in screen-detected tumor characteristics or biology. So the purpose of our study was twofold: to compare DBT and DM screening performance in a community setting, and to compare DBT and DM in terms of tumor characteristics of screen-detected cancers. This was an IRB-approved retrospective review of all breast cancers identified on DBT or DM at 4 outpatient private practice sites. This was the data collected from the electronic medical records, and these were the calculations that were made. Results, I'm just going to highlight the important findings. Patients diagnosed with breast cancer based on DBT screening were on average younger than patients with DM-detected breast cancer. And the cancer detection rate for DBT was significantly higher than that for DM. Cancers detected on DBT were more frequently invasive, and the DBT-detected invasive breast cancers were more often low-grade and node negative. There was no significant difference in receptor status of invasive breast cancers between DBT and DM. So that brings us to question 2. What were the key findings? In summary, DBT compared with DM had a higher cancer detection rate, 3.4 versus 1.8 per thousand screenings. DBT patients were younger at cancer diagnosis. DBT-detected cancers were more often invasive, low-grade, and node-negative. These findings are consistent with findings from other studies. However, our study was performed in a community setting. And that brings me to question 3. What is the significance of these findings? Well, there is increased cost of utilizing DBT compared with DM, and the increased costs associated with large-scale DBT use in the community make it all the more important to assess its benefits, particularly in the community setting. Based on findings from our study, current insights into the impact of DBT on screening performance and screen-detected cancers appear to generalize beyond trials in academic centers to the community setting. Of course, we do need further studies, particularly analyzing the cost-benefit ratio of large-scale DBT use in the community. Also, we need more multi-center long-term studies assessing any differences in clinical outcomes, including mortality of DBT compared with DM. Please refer to our article, which is available online, and thank you for your attention.